All right, we're going to get started, and thank you for joining us. Welcome back to our Wednesday webinar series. We took last week off because of our carefully planned and socially distant legislative conference in Duval County, and today we're going to go back to our really least favorite topic, and that is on COVID. And as we were preparing for this, I thought of something that was almost unthinkable back in March. I was sitting in one of the meeting rooms at the State Emergency Operations Center. They were doing their morning call to the county IEM directors, again, talking about COVID testing, logistics, all of that stuff. And somebody brought up on the call to the state coordinating officer and said, I hate to bring this up, but is anybody talking about hurricane season? And everyone's mouth dropped in the room, and really something that was unthinkable. But the state, in fact, had created a planning cell to begin working on some of those issues. And so today we're going to just kind of go back and with our presenters today, talk about some of the COVID and COVID modeling that's out there. I know there was some unfavorable reports in the paper in the past couple of days about a former state employee on some of the modeling that she has done. But our presenter today, our presenters, is IEM, Innovative Emergency Management. They are a FACT corporate partner. They are a full-service emergency management firm based out of North Carolina, and they have done work all across the United States and including Puerto Rico. And so what they're going to talk about, again, is some of the modeling that they have done, and many of the counties may have seen this. They send out an email before noon every day and show their artificial intelligence modeling projections that appear to be spot on. And then we're going to talk a little bit about the modeling for vaccine distribution, and then finally kind of wrap things up, because we just ended hurricane season and we really, I think, missed the bullet on several of these. We're going to talk about some of the funding between the Stafford Act, the FEMA disaster programs, and then the CARES Act funding. And so with that, I'm going to turn it over to a good friend and someone that most of you probably know. It's Brian Kuhn. He is the Vice President of IEM for Homeland Security. He's the former Emergency Management Director under Rick Scott for the state of Florida, and former Chief of Operations for Emergency Management at Walmart Worldwide. And so just with that as a little bit of background, Brian, I'm going to turn it over to you, and you can present your guests as we go through.
Thanks, Eric, and thanks for having us here to discuss your least favorite topic. We've titled, as you indicated, we got a lot of ground to cover today. So we've titled this A Holistic Approach to COVID-19 Response and Recovery. We've got three of IEM's subject matter experts to go through those topics today with you all. We're happy to answer questions. Use your chat box or the Q&A function on there, and we'll get to as many of them as we can today. And if we're not able to get to them, we'll communicate answers and responses to you through FAQ afterwards. Next slide, Eric. A quick background on IEM. We are an emergency management company, been in business for over 35 years. We were founded in Baton Rouge by our CEO and owner, Madhu Berrywal, and moved to North Carolina about a dozen or so years ago. Nobody you will see today is actually based in North Carolina. I'm in Tallahassee, live down the street from Eric. The rest of our presenters are in Washington State, Maryland, and Virginia. And so we are a very widely dispersed company. We work in all 50 states, multiple territories, Washington, D.C., and internationally. We do focus primarily on Homeland Security and emergency management issues, but over the years, we've done a lot of work with Housing and Urban Development, Health and Human Services, Department of Defense, a number of Small Business Administration, a number of other organizations. So we have a lot of clients at all different levels of government, a lot of experience. If you can think of a natural or man-made disaster that's occurred in the last 3.5 decades, we've probably had some involvement with it. And we do have a full service office here in Tallahassee, as well as in 10 other spots around the country. Next slide. The folks that you'll be talking to today are associated with a component of the company that we really formalized this year called IEM Med. You'll hear from Dr. Sid Bockham here momentarily on some of the work that he has done over the last many years for IEM, but We coalesced all that together this year, recognizing the need that existed to bring together those parts of the company to specifically focus on what it is that we can do to assist our clients with their response to and preparation for other aspects of COVID. And so we've been working on that for 9 months or so. We've got lots of different customers across the country, including the state of Florida, where we're assisting on some of the COVID recovery efforts under Charlie Axon's purview, who we will meet here in a little bit. And we started a work group a couple of months ago to start addressing the vaccine distribution needs nationally. So we're actively engaged with a number of clients on helping them think through and implement their strategy for distributing the vaccines that we're going to all start receiving here very quickly. So with that, without any further ado, I want to bring up our first guest, Dr. Sid Baucom. Dr. Baucom, Sid, is a computational epidemiologist expert. He's been doing that for over 20 years. He has experience in medical consequence modeling and simulation of disease outbreaks and medical consequences following hypothetical attacks with biological agents or emergent infectious diseases. So Sid, take it away.
Thanks so much, Brian. Next slide, please. Yeah, so just real briefly, here's a little history of the modeling that we have been doing to support federal agencies and state and locals. It all started in 2003 for me. We were asked to join the HHS Secretary's Anthrax Modeling Working Group. And since then, we've been supporting HHS. We were supporting BARDA before they became BARDA. So in fact, BARDA came into existence in 2006, the Biomedical Advanced Research and Development Authority. As some of you may know, they are the ones who are tasked with trying to find the medical countermeasures that are required for anthrax, smallpox, and obviously with COVID. So BARDA plays a big role in that. And the modeling work that we've done supporting BARDA has also been presented to the Office of the President. I think something that we really learned quite a bit from was 2009 with the H1N1 pandemic. I think everybody will agree that that pandemic was a totally different beast than what we're dealing with COVID right now. Next slide, please. So just real briefly, a philosophy slide, right? When it comes to modeling COVID, some people choose to take a long range forecast. Our analogy is, that's like trying to predict the entire 2020 Atlantic hurricane season. They did this in May before the season started, projecting out several months out in advance. But with IEM, especially with COVID, our philosophy is really, to keep it simple, make it actionable. And so because of that, our forecasts are only short term, just 7 days, because obviously the further you go out, the more uncertainty there is. And again, with our roots in emergency management, we want to make sure that we're supporting the people that are making the decisions. So, a forecast for the nation is not going to help the state of Florida. And likewise, a forecast for the state of Florida is not quite as informative as a forecast for your particular county. So we were excited when the data came out at the county level. And that's what we use so that people all over the state of Florida and across the country can benefit from these COVID projections. Next slide, please. So this is my very, very non-technical description of our AI model. This is Tow Mater from Cars, and he says, I know where I'm going because I know where I've been. And the modeling translation there is pretty simple. It's projections that we are making are actually based on the past data that we've seen. In this case for COVID, cumulative confirmed cases. Next slide, please. So something that you folks in Florida are quite familiar with is the hurricane models, right? And that's really kind of what we based our modeling on. So first of all, we did not want to create a complex model because there are just way too many modeling assumptions that we don't know, modeling parameters that we still, 8-9 months later, do not have a firm grasp on. So we went with the simplest disease model that we could. That's called an SEIR model. S for susceptible, E for exposed, I for infectious, and R for recovered or removed. So we added to that SEIR model components that represent hospitalizations and ICU care and ventilators. These are all things that are helpful for planners. So the one big thing that we do not assume is about the secondary infections that are caused, right? So that's often called the R value, or the basic reproductive number. And the real simple thing to remember there is if it's under 1, we're doing great because the outbreak is going to stop. And if it's over 1, then it's going to keep increasing. And when we first started COVID, people were talking about an R value of anywhere from 2.5 to 3.5 secondary infections. And that's huge. But what we've learned right away is that R value actually just changes over time, and it changes pretty rapidly. And that's not really because of changes in the virus, but it's based on changes in human behavior, right? When we had a national shutdown, when we had stay-at-home orders, people just weren't mixing as much as they used to. And so that really affects how many secondary infections that you can cause. And like we've said earlier, we use an AI model to find the best parameters. That means the best R value, because we know that the R value changes over time. And for every single jurisdiction, we run 4 million simulations to find those best parameters. And so you can see on the picture on the left there, we use 3 windows to see what those best R values are. So, going from right to left, there's the very early on window, right? We know how the hurricane got to where it is. And then there's the most recent window. And that really tells us, because the most recent window is most likely to tell us what it's going to do in the future, right? And so you guys, again, are very familiar with that cone of uncertainty as it goes into the future. Next slide. So as was described earlier, we've been creating these daily reports that are PDF files, and they get emailed out every day. We started doing this at the end of March of this year. We cover all 50 states, the District of Columbia, 3 US territories, and 376 individual counties. So when you add all that up, we're doing over 1.7 billion simulations every single day. And to this point, we've created and submitted and sent out over 10,500 reports every day. In addition to that, we have also created a web-based dashboard. This allows people to jump on there, see their individual counties and states, and if they're really interested, they can look and see how the other states are faring as well. Next slide, please. So specifically for Florida, we were able to speak with the Bradenton Herald back in April. They wrote a nice little article talking about our AI model and the models and projections that we make. So right now, there are 67 counties in Florida, and currently IEM models 22 of those counties. And that includes the top 12 counties with the largest COVID cases, and also 20 of the top 25 counties with the largest COVID cases. Next slide, please. So this is what we send out every day. So as you can see here, these are the 22 counties. We show people the actual confirmed cases, and then we project out forward 7 days. And so here, this was a projection that we made back November 24th that went out till December 1st. And on the right-hand side there, we've added the actual cases. And so you can go down for every single county, the actual cases, and you can compare them with the projections that we made. And you'll see that going from top to bottom, we're doing really well in terms of forecasting 7 days into the future. This is what you might expect. So on average, our accuracy is right around 100.7%. Next slide, please. So, all the modeling work that I've described has been done to help planners. And so it's great to talk to you folks here in Florida. And, I just want to throw this out there. What else can we help to do to support Florida? So obviously we can add any additional Florida counties that are desired. So as you saw, we've got 22 counties. If you reside in any of the other counties that we don't include in our reports, and you'd like to see that, we can do that. Additionally, we can create some customized regional reports. So for example, on the right there, you see the MWCOG, that's the Metropolitan Washington Council of Governments. So that's Washington, DC, and the surrounding counties. And so for them, it was really important not just to see the number of COVID cases in the District of Columbia, but for visibility and for continuity, for all the folks that live around them. They wanted to be able to see all the counties and their COVID cases. So you can see here's a map of the cases that they have by county. And this is one of the reports that we customized for them. We also customized similar reports for Atlanta and the Raleigh-Durham area and North Texas, for example. And so I was looking, I wasn't able to find a Council of Governments in Florida. But again, if there are places, such as Miami-Dade area or other places that are interested in a customized regional report, please reach out to us, and we can work with you and create something to help you see the cases in your region. And then finally, we're currently supporting Los Angeles County and looking at, how do they do their COVID vaccination strategies? Where do they distribute them, and so on. And also in modeling the benefits of the vaccination. So that's something that we might be able to help you with also. We know that we want this last mile of actually distributing and dispensing the vaccines is very critical. I know there's a lot of ethical issues and so on, but modeling is there to help. As I always say, there's a lot of questions, and if you can identify those questions, more likely than not, modeling can usually help to address those questions and inform your decisions. So that's all that I've got, and we'll wait till the end for questions, but I'll be happy to take any at the end. Thank you.
Thank you, Sid. And as a reminder to everybody, enter your questions in the Q&A section or the chat section. Next up is IEM's Medical Director, Dr. Rashid Chotani. Rashid's resume is extensive, and I encourage you to go take a look at IEM.com to take a look at the full extent of it. But he is a recognized expert in the identification, surveillance, and diagnosis of human and zoonotic infectious diseases such as brucellosis, anthrax, plague, and hemorrhagic and viral diseases. And you can often find Dr. Chotani on Fox News and other news channels every week, updating the nation on the status of COVID. So Dr. Chotani, take it away.
Thank you. And thanks for having us to talk about this very important issue, specifically related to vaccines and planning. Next slide, please. So I just want to go through some of the vaccines that are potentially coming out. And we know that Moderna and Pfizer, two of the vaccines will, Pfizer obviously is going to be the first one to get the emergency authorization use, but Moderna is going to be following very quickly. But if you take a look at AstraZeneca, Janssen, which is Johnson & Johnson, and Novavax vaccine, it looks like it will be next year before they will be able to get the emergency authorization use and the population in the US be able to use those vaccines. So just want to keep that in mind, that we'll have just two vaccines, during December, January, February, and March that we'll have for our population. Yes, the vaccines are here, but it will take some time for the entire population to be vaccinated. Next slide, please. Once the vaccine comes out, there are a couple other things that happen in terms of ACIP taking a look at it and then determining who's going to be on the priority list for getting the vaccine. We understand that very well in terms of what's going on within CDC, FDA, and ACIP. I sit on some of the committees to where some of these decisions are being made. So IEM understands firsthand, what your needs potentially can be, and we can guide you in terms of the documents that need to be produced and help you with the recommendations. Now, one of the things that happens is that ACIP and CDC makes a recommendation in terms of what the priority list is, but the states have the prerogative to do what they actually want to do in terms of vaccinating their population. So we've, as Brian had mentioned, we had put together this vaccine group a couple months ago, and we've been extensively studying it. If you get an opportunity, I would suggest that, or maybe we'll provide you with a link of something that we just wrote and put up on our website yesterday, which is called A Vaccine Journey, that kind of describes as to how this has all happened and why this has happened. Now, one of the things that needs to be clearly understood, that this is going to be a safe and effective vaccine, and that communication for the states and the jurisdictions is going to be critical in terms of providing to the population, so they feel that they're comfortable. One of the things that has to also be part of that yes, Operation Warp Speed has been extremely successful, but we as scientists have been working on the COVID or SARS vaccine essentially since 2003. So it's been a 17-year journey of trials and errors, and now with all the things combined together, with all the resources provided in a very expedited way, we've been able to come up with a vaccine that potentially can be of tremendous utility to the population. Next slide, please. So this is a very heavy data related chart. So what I want you to understand and everybody to kind of grasp over here is that, we have a population of approximately 328 million people, 14 million people to date, or 15 actually, if, this was put together a few days ago. So 14 million is no longer the case. 15 million people have potentially been infected that we know, which is about 4% of the population of the United States, or 4.6% if we take 15 million. For herd immunity, we require about 60 to 70% of the population, to either get exposed or to get the vaccine, to develop immunity against it. So, we've got a huge gap over here, and that 60 to 70 million, 60 to 70% population means about 200 million people in the United States. That's a very large number. We understand that each state is going to get some, and each jurisdiction is going to get some of the vaccine. And let's talk about how much vaccine is available. So in December, we will have combining Moderna and Pfizer both. And if both of them get the emergency authorization use, both of them have currently scheduled to provide us with 40 million doses in December, 50 million doses in January, and in March and February, 60 million doses. That adds up to exactly 150 million doses, or 75 million people can be vaccinated. Now, the priority is going to be that we vaccinate healthcare workers and nursing home and long-term care facility people first. That's what ACIP has recommended. That is approximately 26 to 27 million people. So in the first run, obviously, once we start vaccinating those people, there's going to be very limited amount of vaccine for anybody else. But as we move forward in time, we have essential workers that add up to about 87 million, high-risk population in the US, which includes children, although this vaccine has not yet been approved for children or has been tested in children, is about 100 million. And then we have about 53 million people who are in the adult category. And all of these don't add up to 283 million, but it gives you a rough idea of what the population looks like. So again, only 75 million people will be able to be vaccinated till March. So, and that has to be done in a very expedited way, provided there are no glitches, no problems. Unfortunately, we don't have a unified federal strategic plan for vaccine distribution right now. We have a huge problem with trust in the vaccine. We have issues related to cold change management and transportation of the vaccine. We still have to think about, and states are saying and thinking about, and there's no clear pathway to equitable distribution, or no document has clearly come out that talks about it. We have logistics that have to be looked at, and then we've got program management. Now, the reason that I've put those in red is those are questions that need to be looked at by any jurisdiction that is thinking about vaccine distribution. And what we can do is we can at IEM, we can assist you in dealing with almost all of those questions. If you can go to the next slide, please. So our vaccine group has been looking at all of this, and in terms of how are we going to plan things, what are the logistics, how are we going to provide the vaccine, how are we going to track it? So in planning, we've got to define and estimate critical populations, determine approach for phased vaccine administration and monitoring, review jurisdictional plans and the providers that are available over there that would be able to vaccinate, who have the facilities, who have the refrigeration capacity. And then we have to provide training and conduct vaccination exercises as soon as possible, because this vaccine is coming out this month, this week, potentially. So we've got to be really, really moving at warp speed in terms of doing all this planning, logistics, ordering and tracking the vaccine. Yes, the vaccine now has each of the vials has, each of the batches have a code attached to it. It has time temperature indicator, which is tremendous, but still we need to track the vaccine and the vaccine administration and the second dose of the vaccine that needs to be administered, and make sure that the people who get the first dose are getting the second dose from the same batch that they received the first dose from. So it is not going to be that if you have X number of vaccines that you can just use all of them. You have to keep half of them for the people that have to come back after 28 days or 21 days, depending upon which vaccine you're using, to vaccinate them from the same batch. It is very critical that that happens. We have to enroll people and then track them, expand scope of the healthcare licensure, who can administer the vaccine legally, thinking about all the malpractice issues and all the other issues that need to be considered, the HIPAA guidelines. Again, we have to train people, and then if there are volunteers, we've got to keep a track on the volunteers in terms of their management. Next slide, please. Again, we have to identify the gaps, okay? And identify on the map the populations, the priority groups, the equity considerations, and I believe the most important aspect, we'll have the vaccine, it's going to be safe and effective, but we've got to convince our population that this is a safe and effective vaccine, and it is to be taken and not to be ignored. And for that, we will have to have information on vaccine providers, statewide media campaign, public service announcements in a big way, and we've got to target populations that are minorities, that are specifically, not convinced when a federal government or any agencies pushes vaccination. And then we've got to have hotlines to address questions and processes. We've got to figure out a way how we're going to track, from a state perspective, any adverse effects, and monitor what's going on. And then, as Sid said, with the modeling that we can do, we can track it, and then we can tell you what potential outcomes results after X number of population has been vaccinated. So, those are the critical things. And there are many more questions, I am sure, that are still out there that need to be looked at and addressed. And with that, I will end. I believe that's my last slide, and answer any questions if there are later on. Thank you.
Hey, Dr. Chaitanya, we have one from Joe Morrissey, who asks, when will vaccines be available for children? Well,
at this particular point, they are going to be at I believe, next year, not before that. Because children at this particular point, neither Moderna nor Pfizer has done any of the trials, the clinical trials, which involved children under the age of 12. Most of them were over the age of 18. So we've got to wait to see all of the effects of the vaccine in the first few months on the adult population, and then think about moving into children. Now, the AstraZeneca vaccine, the Oxford AstraZeneca vaccine, is enrolling children right now in the United States for its phase 3 studies. So we will have some data on that. Now, that vaccine is also very effective, 75% efficacy. So So we've got a very clear path in terms of succeeding to vaccinate the entire population. The other thing that we have to think about is, and why is it that we are not really saying, or ACIP or CDC is saying that we got to vaccinate children first, right? We've got to vaccinate, people that are taking care of the sick first. Then we've got to vaccinate people where we have the highest number of hospitalization and mortality. That is the nursing home population. Those are the senior citizens. Then we have to think about, essential workers, which includes firefighters, police officers, other medical facility workers. And then we have to think about all the other adult population, and then comes down, and in the adult population, we have to vaccinate teachers. They are potentially essential workers also. So teachers in schools, K to 12. And then at the end, we have to think about the kids. Now, the kids do get infected, but the mortality among kids is the lowest, and we don't want any mortality, to be honest about it, but we've got a limited amount of vaccine. So if we vaccinate all the vulnerable population first and do the kids later, then we will be able to minimize hospitalizations, minimize deaths, and we'll be able to contain this virus in a much better way. I hope that addresses or answers the question that you had, sir.
Great. Thank you, Rashid. Appreciate it. And as a reminder, anybody who has additional questions, enter them in the Q&A or text box, and we'll circle back to them at the end of Charlie's presentation. And with that, I'm going to introduce Mr. Charlie Axton, who is our Manager of State and Local Response and Recovery. Charlie is a long-term FEMA expert. He worked for FEMA for about 20 years, and for the last 5 or so has been working in private industry, helping clients work through the sometime Byzantine FEMA regulations in order to get their reimbursements. So with that, Charlie, I'll turn it over to you.
Thank you, Brian, and thank you everyone for having us today. So today we'll talk about 3 federal programs that are available for the COVID-19 event that are of great interest to counties. The first one is FEMA's Public Assistance Program. Second is the CARES Act Coronavirus Relief Fund, available via the Department of Treasury. And then lastly, the Community Development Block Grant available for the coronavirus, the CARES Act authorization from HUD. Next slide, please. So here are some kind of high points on FEMA's Public Assistance Program to be aware of. First, Disaster 4486 was declared for Florida by the President on March 25. All counties in Florida are included in the disaster declaration, and the declaration provides reimbursement of eligible emergency protective measures, considered Category B for those who are familiar with the program, for costs that are directly attributable to the pandemic response. The incident period is January 20 and continuing. The closure date of the incident period is currently uncertain, as are many things, as we all know, with the pandemic. And FEMA has provided guidance that it will notify everyone within 30 days before the incident period is closed. So again, it remains open. The FEMA program is subject to a cost share, 75% federal, 25% non-federal. In Florida, for public entities, the state provides half of the non-federal. So for counties, 75% federal, 12.5 state, and then 12.5 county funding for eligible costs. FEMA has a grants portal system where projects are submitted, and I know many counties have already done that. If you haven't yet, I would certainly encourage you to push those through. Duplications of benefits or assistance must be avoided. There are a lot of assistance that might be available for some of these costs. You just have to make sure that they're each tailored so that they are complementary and don't inadvertently have some duplications in there. One of the common scope items and cost items is personnel. And I think it's important to keep in mind with FEMA under the Public Assistance Program for emergency work, think of it in terms of extraordinary costs are potentially eligible, whereas budgeted costs are not. So overtime for budgeted employees would be eligible, regular time for budgeted employees would not. And then similarly, regular and overtime for unbudgeted employees, along with all associated benefits. Again, extraordinary costs are what FEMA considers eligible. Regarding emergency or exigent procurement actions, FEMA has specific guidance on that. Definitely encourage everyone to be aware of that because that's common in emergency circumstances, certainly for this pandemic. And FEMA's PA program, public assistance, is administered by FDIM, by the Florida Division of Emergency Management as the recipient. Next slide, please. So this slide provides a lot of information about what FEMA considers eligible for funding for emergency protective measures. And you'll see the two columns. The left column is for work performed prior to September 15, and then the right column is on or after September 15. Basically, the first 6 months or so of the event, FEMA produced kind of broad and general guidance about what kind of emergency work could be eligible. I would describe it as generally inclusive. And then on September 15th and after 6 months or so of this response, FEMA evaluated other funding programs that were available and the types of emergency work that was considered appropriate for FEMA funding, and they issued a policy that became applicable on that date. And now it's very specific. It either has to be listed on that policy as being eligible or it is by default ineligible. So I'll let folks kind of go through those items after the fact. But again, it's important to keep an awareness of that September 15th date and what that means as far as what's eligible, the types of work, and the associated costs that are eligible on or before that. And I think a great example is sort of disinfection and PPE that are commonly used throughout county government, or if you're in a school district, within a school district, on or after September 15th. In order for those PPE disinfection costs to be eligible, they have to be specifically associated with the performance of those emergency measures that FEMA is considered eligible, such as medical care, non-congregate sheltering, EOC operations for the pandemic. Whereas prior to September 15th, there was some broader allowances on eligibility of disinfection and PPE. And we're seeing some challenges on FEMA's part on how exactly they're pushing forward those funding decisions even before the 15th. And all the items that have a little asterisk next to it mean that there's a specific FEMA policy that has been issued for each of those topics. Next slide, please. So the next program is the CARES Act Coronavirus Relief Fund, the CRF. This is the Department of Treasury program. $150 billion appropriation nationally, 8.33 billion of that's the national amount or the maximum amount for Florida. 12 jurisdictions in the state receive direct allocations. The others are via FDIM as the recipient. Important point on this funding can be used as the non-federal match that we talked about on a couple slides ago on FEMA's PA program. We're seeing a lot of counties and similar jurisdictions throughout the nation using their CARES Act CRF funding for exactly that. So that's something to fully consider when you think through your planned approach to the CARES Act. The funding allowances kind of fit into three broad categories. First, they have to be directly, result of the public health emergency. Second, they have to be not previously budgeted as per that date listed. And lastly, the costs associated with the use of this funding amount has to be incurred between March 1st and December 30. Next slide, please. So here are the types of expenditures that can be eligible with the CARES Act CRF. Just the 6 categories are medical expenses, public health, payroll, expenses to facilitate compliance within the community, expenses associated with economic support, and then other COVID-19 related expenses. The CARES CRF funding has a lot of allowances in each county, each recipient, each subrecipient receiving this funding and tailoring it to meet your needs. And that's, I think, one of the great strengths of this program. Next slide, please. And the last program that we'll discuss is the HUD, the Housing and Urban Development CDBG-CV program. Again, this is the Community Development Block Grant for the coronavirus. The national amount for this is $5,285.6 million for Florida. And again, just two quick points on this. At least 70% of the funding must be for those activities that benefit LMI, low and moderate income individuals and families, for housing, employment, public service, or access to new or significantly improved infrastructure. And the remaining 30% may be used for elimination of slum or blighted conditions and address urgent needs that are not otherwise funded. So that is a quick overview of kind of the three primary, or at least three programs that are of significant interest to counties in Florida. Thank you.
Thank you, Charlie. And I think Eric has a few questions. I'll ask one first, though. There's about 3 weeks left in the year to spend that money. Any last minute tips for anybody? Can they go buy $100,000 worth of gift cards, for example, or how can they utilize that?
Yeah, on the CARES CRF funding, is that?
Yeah, that's what I mean,
yeah, you're right. That is exactly 3 weeks. And you know, I think that's a tricky one. It's there's a lot of opportunities. I mean, there's a lot of hope that this will be extended. There's a series of legislative actions that have been explored. As of today, the December 30th date remains fixed, so we can't assume that will happen. Yeah, I would say, you know, if you can find a way to get that funding to be earmarked for specific actions that are necessary for those 6 categories that we talked about earlier, for economic recovery, for community or businesses within the community, direct assistance to families, county incurred emergency costs. If you can put those in a category on your expenditure sheet where they're committed, even if there's not specific invoices or those, that we're seeing that there can be some potential for that to fit satisfy the grant requirements, the assistance requirements for the CARES CRF Act. So hopefully that's specific enough, Brian. I think it's difficult to go out and spend the money on actual expenditures where, you know, a vendor is paid for those. But if you can put them on your balance sheet as earmarked for allocation or for expenditures, that should and could address that December 30th requirement. Good.
Thank you, Charlie. Eric, I'll turn it over to you.
Thank you. And my question's for Dr. Chaitani. Your data intensive slide had some information up there. You said that it's really a transmission question. I think you said 14 million have contracted the virus, about 4% of the population. How does this compare to the annual flu that we see in terms of affected? Is there something unique about COVID-19 and the way it spreads that is different than the seasonal flu?
Yes, definitely. And we are still learning about COVID-19. I mean, the amazing thing about this virus is that we don't know who it affects, who it infects, and why. There are case studies right now that demonstrate that in one household, somebody has brought in the disease, and not all the members of the household were sick. So we are still learning about the disease and how it spreads. We know that, it's got a R naught value, which, as Sid has mentioned earlier, fluctuates. And, it'll take us time to understand in terms of how this disease spreads. I mean, we've got about 80+% of the population, I would say, by some estimates, 14% of the total US population is right now infected or has been infected with the disease. that still leaves about 86% of the population that's vulnerable that has not contracted the disease. Problem with this disease is that it affects in a very, as I said, in a very bizarre way. And what we've seen is that, a lot of people get some really adverse effects of this disease and they're hospitalized. So if you combine 5 years of all the deaths caused by influenza, last 5 years, this year with COVID, we've had more deaths. So again, we still have a lot to learn about this disease. I'm not going to go out and make claims about, that we know everything about it. We still don't know, what are the long-term effects of this disease because we've not had this disease for a long time. The only case study that we have is from 2003 and 2012, when we can take a look at SARS and MERS coronavirus and how, it affected people. But this one is not doing the same thing as it did in those two outbreaks, which were similar, the same virus, essentially, a deviation of the same virus, but a same virus, essentially. So we're still learning, and we have to be very careful and cautious as we move forward. Again, one of the most important things, till we all get vaccinated and we have herd immunity develop, we've got to rely on the basic non-medicinal methodologies that is masking, social distancing, and hand hygiene.
So since this strain of virus is same but different, has been, as you said, studied for several years, do you think that the scientific community has learned anything in terms of developing this vaccine? So whenever COVID-20 or 21 comes down the road, that they can develop the vaccine quicker and get it out for distribution faster?
Yes, absolutely. So, the lessons that we learned and from 2003 and 2012, when vaccines were tried and they tried to develop vaccines as well as monoclonal antibodies, as well as antivirals. None of them essentially really worked. And what happened was that the disease intensity, of course, SARS appeared and then completely disappeared in 2003. MERS appeared, and then in 2013, we had a lot of cases globally, and then it slowed down and it kind of settled in the Middle East, and that's where it stays, and the intensity is very low. So there was no serious interest in taking what we had done to the other extreme, making a finished product. Finished product meaning having a vaccine or a therapeutic, whether it's an antiviral or a monoclonal antibody in a bottle that can be administered or taken by individuals. So now with all that science, with all the investments and the resources that were allocated through Operation Warp Speed, a journey that would take about 10 years or maybe more took less than 9 months because of the knowledge. So next time, yes, there is going to be definitely an advantage in terms of developing vaccines, coming up with things. And, we have understood that mRNA vaccines, take a shorter period of time to develop and manufacture. That was not the case earlier. Now we know that. We know that, we can come up with some monoclonal antibodies and they demonstrate efficacy and effectiveness. So those are the kind of things that we've learned, and those are lessons that are going to take us forward. And in a very positive way. Infectious disease research had essentially stopped for many, many years. And we were focusing on chronic diseases because chronic diseases, heart disease, cancer, various other diseases were plaguing our nation in a much bigger way. But now we've realized that we still have to continue to invest in infectious diseases. There are 6 or 8 other viruses that potentially have pandemic threats that are now being taken very seriously and being considered, and NIH is going to be working on developing new vaccines for those viruses also.
Dr. Shatana, we have a question in the chat, and it says, is there a practical difference with a vaccine that has reported 90% effectiveness and 75%?
Of course, there is a difference. That means that you have a 90% probability or 95% probability of not getting the disease versus 75% probability. But in the big picture, if we are talking about the big picture, it really doesn't matter, because what we are trying to do is create herd immunity across the nation, which means 60 to 70% of the population getting some sort of immunity, whether by exposure, whether by vaccination. And once we attain that objective, it is not going to matter, in terms of how effective the vaccine is. Now we know that the only other vaccine that is effective to that particular point is the measles vaccine, which is 96% efficacious. And we've got other childhood diseases that we have been able to control with vaccines that are much, much, much less effective. So what we want is to have the herd immunity, whichever vaccine we use, we should be able to get to that particular point. The critical thing is to provide safety to all the people that get the vaccine, just so that everybody understands that the first dose of the vaccine does not give you 95% efficacy or effectiveness. It just gives you something like 65% efficacy. So you have to get the second vaccine, and it takes then about 2 weeks for you to actually develop the immunity that will protect you 95% of the time. So it takes time, even for the vaccine, from the first vaccine to the second vaccine to 2 weeks, you're talking about almost 1.5 months that you got to make sure that you're still protected till you develop that strong immune response in yourself.
Great, great answer. Thank you. This is, Brian, what I've noticed about this, I'm going to call it event because I'm trying to think, the emergency management hat on, is this is where like science and public policy have really intersected with COVID-19. And so I'm going to kind of ask maybe more of a public policy question of you and maybe Mr. Axton about, there are some, I think, pivotal moments, I think, that have really changed public policy in this country. 3 Mile Island was one in the emergency management world. Hurricane Andrew was another. So monumental changes occurred at the federal level and really in Florida in emergency management. 9/11 for terrorism. But now I think it's COVID-19. And so for our elected officials, they're learning as they go. But from where you sit, what do you think are some of the, important takeaways, lessons learned, things that we need to have our counties get ready for, really for the next pandemic? Because I think this is something that no one really took seriously, even though we had H1N1. No one really had this on their radar screen outside of sort of the niche elements in the emergency management community and departments of health. So what would you say are some important things for counties to think about going forward as we, get vaccines out there? People are going to begin to kind of let their guard down. What do you think are some of those best practices and lessons learned?
So I concur that I think this is a seminal moment, that 2021 will be one of those years where we reflect on COVID as well as the busiest hurricane season, the busiest wildfire season in the West, civil disturbances and riots. So 2021, we're ripe for change and improvements at all different levels of government. So I would encourage folks at FAC to consider what can they do locally to do that, as well as push the state legislature and the governor, as well as push Congress and the president to incorporate the changes necessary and that would have been useful this year, to do the after action reviews, to consider how they could improve things locally. Think through things like your continuity of operations there at the local government. Think through things like how you structured your emergency management and your health organizations within the county. Were they appropriate? What could you do to protect yourself better against those in the future? We have an awful history of ramping up and then letting those things slide before they need it again. So how can we do a more sustained, consistent effort there? Think about how that you as a jurisdiction can handle multiple cascading events. Many folks across the country were dealing with COVID, wildfires, and riots at the same time. I did a webinar last week with the Oregon State Director, and they had all three things going on at the same time. So how can you structure your organization to do that? And you can't, nobody has the resources and the funding to make their emergency management agency big enough to do that. So how can you spread that across all of the government agencies you have and the resources you have to be able to meet that need. And I think, continue to think about, it's probably not going to be 100 years before the next pandemic. And it's going to be some other health issue. So consider that and think through, the stuff that we're dealing with on an everyday basis with drug addiction and nutrition issues. This is kind of an offshoot of that. So think, maybe perhaps more holistically about the health of your community and ways to support that. And then finally, I'd say, and then I'll ask Charlie to chime in. Well, two things. I want to say, think about funding across the board, how you handled this and how you may handle the next thing for your community, which could be climate change and sea level rise. It could be a catastrophic hurricane. How can you help prepare for that? And then I think that was my final point. Charlie, what do you think?
Yes, I think those are all key points. And I think the only thing I'll add to that is just the role of the individual, the family, the community overall, and how they interrelate with their local elected officials and within their community, and how we can, as emergency managers, advise local elected officials and certainly the general public as to embrace their role in all of these things. That's not a new thing for emergency management, for hurricane preparedness or any other actions, but certainly how that fits in here for pandemic events and other types of events that are on the horizon that we're not thinking about today because of everything that's gone on in 2020. And yes, at the county level, at the local elected official level, how we can collectively bring individuals, families, and members of the community into that whole process.
Hey, Eric, one more thought on what you highlighted before, science and public policy. We will see that again in Florida in hurricane season. So right now, trust in government, faith in government leadership is not where it needs to be. And that can prove deadly the next time we try to encourage people to prepare for a hurricane coming towards the state, to evacuate to a place of safety, et cetera. So we need to do everything we can in the next 6 months to build that up and get that trust, that flow of communication with our citizens so that they are receptive to those and willing to do life safety things when we ask them or tell them to. I think that's going to be a hard part of 2021, is to rebuild what we have lost. And be prepared to counter misinformation, disinformation, not just misunderstanding, but active disinformation campaigns coming from locations. We're going to have to be able to counter that in the upcoming years for upcoming disasters.
Totally agree. Brian, looks like we got one last question, and I'll read it if that's okay. And I was going to ask this earlier, but it says there's uncertainty about the longevity of immunity in those that have contracted the disease. What is the longevity of immunity from the vaccines? I think this is for Dr. Shitani, I think.
Absolutely. Very, very important and a good question. So what we have so far observed looking at the disease and the immunity is that there's some studies that have come out from China, and there is some anecdotal information data that has come out in the US that, at least there is a certain amount, 6 to 8 months, where people get infected and potentially they might be immune. The immunity is illustrated by looking at something called immunoglobulin, the antibody in the body, which develops after you get infected or you are vaccinated and you develop immunity. So we know that. We also understand and appreciate the fact, and let me go back to the experience that we've had in terms of influenza. We always recommend that people get influenza vaccine in October, early October or mid-October timeframe. And why do we say that? The reason we say that we know that the vaccine, the efficacy or the effectiveness of that vaccine lasts for 4 to 5 months maximum. We also understand that, there are outbreaks that happen in the month of March. This we have learned through experience over time, right? So that's why for influenza, we understand that in a much, much better way. For COVID, we still are not really there. We know that people do develop immunity. We know that after getting vaccination, after 2 weeks of the second dose that you receive, you will get about 95% protection against the disease. But we honestly do not know whether the immunity is going to last for 1 month or 6 months or 8 months. I honestly don't think it is going to be a lifelong immunity that you get from the vaccine. I hope it was, but it doesn't, the past with other vaccines, we've not been able to clearly demonstrate that the kind of, the virus that we are dealing with. So yes, there will be immunity, but we'll have to wait for a few months, quite a few months, to find out, how long that is going to be. But it will be in the 4 to 6 months period, at least in my opinion, based upon some of the information or the anecdotal data that I have looked at, where there are individuals who've been infected, and 6 months later or 8 months later, they had a milder form of the disease and they were tested positive for COVID again. So we gotta wait for that. But yes, there is going to be some period of immunity after you get vaccinated, and this could potentially, again, this could potentially be, and as Brian was saying, and as all of us were talking about, how do we develop a resilient community? We've got to think about that. If this vaccine has to be administered every single year, how are we going to deal with that?
That's why this is my least favorite topic. So, but you guys were probably my best guests that we've had on here. I appreciate you taking the time to come on and share this information with our members. Brian, looks like there's no more questions in the Q&A or the chat. So with that, I do want to thank you, all of you, again, for taking the time and coming on to our little webinar today, and appreciate IEM's partnership with FAC. So thank you again.
Thanks for having us, Eric. We appreciate it.
Okay.